In this lecture, we will be covering diseases of the exocrine pancreas. The pancreas has both exocrine and endocrine functions. By definition, endocrine glands secrete hormones directly into the bloodstream. The two hormones from the pancreas are insulin produced by the beta cells and glucagon from the alpha cells. They regulate glucose homeostasis. And this was previously covered in the diabetes module last semester. This lecture, however, will focus on diseases of the exocrine pancreas. The main exocrine function of the pancreas is the secretion of digested enzymes and other substances. These compounds flow as part of the pancreatic juice through this pancreatic duct here, eventually going through the sphincter of Oddi into the lumen of the small intestine. Specifically, it's in the duodenum, which is the first section of the small intestine. This is where the pancreatic juice gets released. This table summarizes the main pancreatic enzymes, their substrates, as well as their action and products of the action. So the products would be what does the hydrolysis of the substrates produce? So this is a good summary to refer to. The enzymes produced by the pancreas are not selective in terms of which tissues or compounds to digest. If it is an enzyme that digests protein, whether it's protein from the food or the protein of our own tissue, they can all be hydrolyzed. Therefore, there is always a risk for autodigestion. Fortunately, our body has certain mechanisms that prevent autodigestion of the pancreas. For example, the pancreatic enzymes, when they are in the pancreas before they have been secreted into the duodenum, they exist as zymogens. They are pre-enzymes that are not fully activated. They will be activated once they reach the small intestine. Also, there is a low calcium concentration inside the pancreas tissue, which also inhibits trypsin activation. And we know that trypsin is a protein digestion enzyme. Once activated, it can activate other enzymes and also self-activate other trypsin proteins, so it triggers a chain reaction. Since we know the secretions of the exocrine pancreas and the mechanisms against autodigestion, if we see an abnormally high level of these digestive enzymes in the blood, we could expect that there is a problem with the pancreas. So, checking serum levels of lactase and amylase, which are produced in the pancreas, is a common test to diagnose pancreatic disease. Monitoring these enzymes is also a useful tool for monitoring the progress and effectiveness of the treatment for these diseases. The main condition we will discuss today is the inflammation of the pancreas called pancreatitis. The inflammation of the pancreas is characterized by edema, cellular exudate, and fat necrosis. In this condition, whether it's chronic or acute, autodigestion will occur. Therefore, there will be tissue necrosis, and it could lead to severe hemorrhaging in the pancreatic tissue. In acute cases, some patients will develop multiple organ failure, which calls for intensive care and can be fatal. So this can be a very serious condition. Different factors can cause pancreatitis. For example, gallstones could cause the obstruction of the common bile duct or at the sphincter of Oddi, and could lead to buildup of the pressure inside the pancreas. Eventually, this could lead to the rupture of the tissue, which could trigger autodigestion. Also, acute or chronic abuse of alcohol could lead to pancreatitis. Obviously, this has an addiction and lifestyle factors involved. Therefore, in addition to acute care, we would need to conduct nutrition counseling, nutrition education, and behavioral therapy in some cases. And of course, trauma as well as certain medications can also lead to this condition. When talking about chronic pancreatitis, we should understand that although it is chronic and may not be life-threatening, it is an irreversible condition. It's an irreversible process that can lead to fibrosis with tissue calcification. So the key word here is irreversible. It may be chronic, but once it starts, we cannot go back. Although it may seem harmless, it could damage the normal pancreatic tissue, which could lead to the loss of function, and this would apply to both the exocrine and endocrine functions. Therefore, the long-term consequences of pancreatitis could be diabetes, because the beta cells of the normal tissue that can secrete insulin may be replaced by fibrous tissue or damaged by abnormal calcification. Also, those cells that secrete digestive enzymes may also be damaged due to this. Therefore, we may see fatty stool because the lipase from the pancreas is severely decreased. Before we move on, let's talk a little bit more about this type of diabetes. So let's think. In this case, although it's secondary to chronic pancreatitis, would this be type 1 or type 2 diabetes? So if we think about the definition of the two types of diabetes, type 1 means that there is absolute insulin deficiency. Therefore, the damage to the beta cells caused by the chronic pancreatitis could lead to absolute insulin deficiency. Thus, people may have type 1 diabetes developed secondary to chronic pancreatitis. Some people with acute pancreatitis do not have any symptoms, although many of them may complain about upper abdominal pain. Some complain that this pain radiates to the back and gets worse when they eat. This is understandable because whenever we ingest food, it stimulates the secretion of pancreatic juice, and this would exacerbate the symptoms. And this pain can really be excruciating. Some patients really suffer a lot with this condition. Also, autodigestion will be triggered. Therefore, there will be severe tissue damage caused by the digestive enzymes, which are basically hydrolyzing our own tissue there. As a result, in addition to the clinical signs and symptoms, we would also see elevated lipase and amylase in our blood. In this case, the physician will check these enzymes at different points over time to observe and see if the patient is still deteriorating or if they are recovering. One thing we need to know, as mentioned, is that acute pancreatitis can lead to multiple organ failure, and this can be fatal. For example, people who have this condition may develop respiratory failure and then be put on a ventilator. Even though the original disease is far from the lungs, the impact can be systemic. Knowing the exocrine roles of the pancreas in digestion, we can understand that for people with pancreatitis, we may have severe digestive problems because the secretion of key digestive enzymes are compromised. And because fatty stool could be an issue, it indicates that there is undigested, unabsorbed fat. Thus, fat-soluble nutrients could be at high risk for deficiency. When we assess patients, in addition to the usual measures we check, we also want to look at the specific lab values. So we mentioned 2 enzymes commonly checked for pancreatitis patients. We also need to have a thorough interview to get patient history to see if there are any lifestyle factors that contribute to the development of pancreatitis. For example, we mentioned alcohol abuse, among other things. Here is a list of problems for nutrition diagnosis for patients with pancreatitis. Hopefully these are pretty obvious by now, and of course all of these would be valid for these patients. The nutrition intervention for chronic pancreas involves recommending that the patient break their meals into small, more frequent events. We also want to have low to moderate fat because they will have limited tolerance of fat. While we keep this in mind, we also want to try to provide as much fat as the patient can tolerate. It is an essential nutrient, and it is the solvent for many other essential nutrients such as vitamins A, D, A, and K. In addition to having smaller, more frequent meals, patients are also given supplemental enzymes. For example, 40 to 50,000 IUs of lipase for each meal, and then a little less for snacks. We also want to use a low-fiber diet. The reason for this is that if we have a high-fiber diet and we also need to have these enzyme supplements with meals, then the fiber will chelate and engage many of the enzyme molecules and make them unavailable. So in this case, high fiber in the diet would reduce the effectiveness of the enzyme supplement. And this is the rationale behind the low fiber diet here. We may also want to refer patients to physicians to obtain medications to decrease gastric acid. So we know that gastric acid is very acidic with a low pH value as low as 2. And when the gastric contents go into the duodenum under normal conditions, we rely on bicarbonate from the pancreas to neutralize the acidity from the chyme from the stomach. Of course, with this neutralization, pH value will increase, and that will activate the zymogens from the pancreas. However, in the case of chronic pancreatitis, the secretion of bicarbonate is already deficient. Therefore, if we don't decrease the secretion of gastric acid, we won't have much bicarbonate to neutralize it, which could lead to 2 consequences. One is that the acid could burn the duodenum tissue, so we could develop an ulcer here. Second, without adequate neutralization of the gastric acidity in the small intestine, we will not have the optimal pH for the activation of digestive enzymes. And this would, of course, lead to maldigestion and malabsorption. Patients with this condition are at high risk for malnutrition due to maldigestion and malabsorption, so we would want to promote weight gain. For this, we would recommend to provide 35 calories per kilo of body weight because due to chronic inflammation, the patient's resting energy expenditure is higher than usual. Also, we want to provide a higher protein allowance and maximize fat as tolerated. Again, they have the decreased ability to digest fat, but we want to make sure to provide the maximum amount tolerated by the patient. We could also add medium chain triglycerides into the diet. And this is because fatty acids digested from the MCT can enter the bloodstream more rapidly than triglycerides from the long-chain fatty acids. So remember, the MCTs are absorbed directly into the portal circulation and transported to the liver to be processed. Acute pancreatitis is a more severe condition. Again, it could be life-threatening. We want to give patients PO intake as tolerated and also break it into smaller meals. Studies indicate that if we break the daily intake into 6 smaller meals, the patients will have better tolerance. Again, we also want to reduce fat intake and supply enzyme supplements. Because of the overall maldigestion and the resulting malabsorption caused by this condition, we may want to provide multivitamin and mineral supplements to help the patients meet their needs. If the patient has alcoholism, we need to provide specific supplementation such as vitamin B1 at 100 milligrams a day and folate at 1 milligram a day. We will also need to provide nutrition education and nutrition counseling. So there are lifestyle-related triggers of this condition where patients need to modify their behavior, such as with alcoholism. Also, there could be compliance issues as the patient has to take many things. The enzymes, the multivitamin supplements, maybe even medication to decrease gastric acid secretion. Patients will need the knowledge and skills in order to be compliant. I do remember a dietitian once told me a story about a patient in his 20s. The patient had a family history of alcohol abuse. His father had alcoholism. And the patient had started drinking in his teens and had developed severe drinking problems, even had to go through a court-ordered 12-step process to address it when he was younger. Now, he probably didn't make the best occupational choice here. He had a job as a bartender, so this is not the best option for him since he already had the issues with alcohol. And he had pancreatitis, but he was admitted for acute pancreatitis. He was vomiting and had very high serum lipase and amylase levels. So his work environment made it difficult for him to stay away from alcohol abuse since he was working as a bartender. But when the dietitian was doing the assessment, the patient, was in a lot of pain, and he mentioned to the dietitian that he had a 2-year-old daughter and that he had wanted to stop drinking for his daughter. And he also told the dietitian that he had a dream. In the dream, he was working and a customer offered him a free drink, which isn't uncommon in that line of work. But he got angry in the dream that he was being offered a free drink, and then he woke up. So the dietitian who interviewed him believed that basically at this point the patient had hit rock bottom, and he was very motivated to change. So this would have been best to follow up with behavioral therapy. This window of motivation is a great time to apply interventions, and we would expect that the results would be good because the patient was highly self-motivated. Unfortunately, the dietitian did not have a chance to follow up because the patient was discharged that day. So unfortunately, we don't know if he received the outpatient counseling. We hope he did, and that he was able to change his behavior. So this is just an example that in addition to dealing with acute nutrition support, we also need to be keeping in mind these lifestyle factors as, when it comes to nutrition intervention as well. So also in severe cases of acute pancreatitis, we want to start early and aggressive nutrition support. So here on this slide are the protein and energy allowances. Overall, as we know, enteral feeding is preferred over parenteral nutrition. We would also prefer to use a shorter peptide as a protein source, which would require less digestion, and also have medium chain triglycerides because these enter the bloodstream directly. And there are enteral formulas that have these components called hydrolyzed formulas. When it comes to monitoring and evaluation, for acute pancreatitis, we want to be sure to monitor weight and also the symptoms. For example, pain. Are they still complaining that they're in a lot of pain, or are they saying that it's getting better? Also, tracking oral feedings, and for the lab values, using those two enzymes as markers to monitor the progress and the effectiveness of the intervention. For chronic pancreatitis, it is very similar. But since it is not as severe or life-threatening, we may not need to repeat the lab test quite as frequently. Of course, monitoring tolerance to diet, weight changes. Remember that we want to promote weight gain, and also look at if there are any symptoms as well as the fecal consistency. So we know if things are left digested, we won't have absorption, and this would all be excreted in the feces.